You know that feeling right around maybe 3 in the afternoon?
Oh, yeah. The 3 p.m. slump.
Right. You're sitting at your desk or, out running errands, and suddenly it just hits you. This massive wave of exhaustion.
Yeah, your hands get a little shaky.
Exactly. Shaky hands, you get that hollow pit in your stomach, and your brain is just screaming one single command, which is find a snack right now.
Yep.
And for most of us, we just grab a granola bar, drink some juice, and we bounce back a few minutes later. We just call it a mid-afternoon crash.
Right, it's just a temporary thing.
But when the body's fuel tank actually hits zero, it triggers a physiological cascade that is so severe, it was actually once used to intentionally induce psychiatric comas.
Which is just wild to think about. I mean, it is a radical shift from a temporary hunger pang to a full-blown medical crisis. And the margins for that shift, they are incredibly thin.
Yeah, and that's exactly what we're getting into today. Welcome to today's deep dive, where we are unpacking the fascinating, high-stakes world of hypoglycemia.
Yeah, for anyone studying nursing or, working in healthcare or just insanely curious about human physiology, understanding hypoglycemia is really a masterclass in how desperate the body gets when its primary energy source disappears.
Totally. And our mission today is to look at the sources and uncover the exact science of spotting and treating low blood sugar fast. We'll be dissecting the famous Rule of 15, exploring some bizarre medical history, and busting myths that could literally save a life.
It's a lot of ground to cover, but it's so important.
Okay, let's unpack this. Looking at the clinical data for this deep dive, it becomes clear that we often misunderstand what a fuel crisis actually looks like.
How do you mean?
Well, I always assumed blood sugar functioned a lot like a speed limit. If the speed limit is 70, driving 69 miles per hour is fine.
Right, sure.
But the second you hit 71, you get a ticket.
Mm-hmm.
And we tend to act like a blood glucose reading of, say, 71 milligrams per deciliter is totally safe, but 69 is an immediate emergency.
Oh, I see what you're saying. Yeah.
But reading through the diagnostic criteria in our sources,
Yeah.
it operates much more like a syndrome than a hard numerical cutoff. Why is the brain so uniquely vulnerable here?
Well, it's because human physiology does not read speed limit signs. The brain's vulnerability, it really comes down to this massive mismatch between its fuel consumption and its storage capacity.
Okay, mismatch how?
So the human brain only accounts for about 2% of your total body weight, but it demands 20% of your body's glucose.
Wow, 20%.
Yeah. It consumes roughly 120 grams of glucose every single day just to maintain basic cognitive function and, keep your autonomic systems running.
That is an enormous amount of fuel for just one organ.
Yeah.
But the real structural flaw, according to the sources, is the lack of a backup generator, right?
Exactly. Unlike our muscles or our liver, which can store large amounts of glycogen for later use, the brain basically has zero reserve tank.
None at all.
Well, there are these specialized glial cells in the brain called astrocytes, and they hold this tiny microscopic buffer of glycogen. They process it into lactate to feed the neurons during sudden high demand. But that local supply, it's exhausted in a matter of minutes.
Just minutes. Wow.
Yeah, so when blood glucose falls, the brain is immediately starving. It literally cannot wait for the liver to slowly mobilize its reserves. It needs a continuous, uninterrupted delivery system in the blood.
Which perfectly explains why the American Diabetes Association, the ADA, why they moved away from just using a single diagnostic number.
Right, they broke it down into tiers.
Yeah, 3 tiers. So level 1 is a blood glucose between 54 and 69 milligrams per deciliter, which requires intervention but isn't necessarily a huge crisis.
Right.
And then level 2 is below 54, where neurological impairment usually begins.
Yep, that's where things get dangerous.
But level 3 is what changes the entire paradigm. Level 3 is classified as severe, but there's no specific glucose number attached to it. It's defined entirely by functional impairment.
Exactly. Level 3 means the person has an altered mental or physical status that is so severe they require active assistance from another person to recover.
So the number doesn't even matter.
The absolute number on the meter is totally irrelevant to that classification. If a paramedic finds someone unconscious and revives them with treatment, that is level 3 severe hypoglycemia, even if nobody actually had the time to prick their finger for a reading?
That makes total sense because, glucose tolerance is so individualized. A healthy person might naturally hover around 65 and feel completely fine.
Absolutely.
But someone with poorly controlled diabetes, whose body has physically adapted to a much higher baseline, they might hit that exact same number of 65 and experience severe tremors and confusion.
Right, because their brain perceives a crash since the relative drop is so steep.
Right.
The central nervous system adjusts its threshold based on what it considers to be normal. So the diagnostic focus really shifts from, chasing a specific number to observing the clinical reality.
Which is the presence of symptoms, a low relative glucose level, and then the resolution of those symptoms when glucose is restored. Speaking of those symptoms, if the brain has no backup fuel, the body obviously needs an incredibly sensitive alarm system to warn you before the tank hits zero.
Oh, absolutely.
And the sources divide this warning system into two distinct families: adrenergic symptoms and neuroglycopenic symptoms.
Right.
When I was thinking about how this works, it really reminds me of a dying smartphone.
Okay, I like that. How so?
Well, the adrenergic symptoms, the sweating, the shaking, the racing heart, that's the low battery warning flashing on your screen.
Yeah, it makes sense.
But the neuroglycopenic symptoms, the confusion, the slurred speech, the loss of consciousness, that's the app's actively crashing and the screen blacking out because the power supply is actually gone.
That is a highly accurate way to visualize it. The adrenergic symptoms are driven by a massive, sudden surge of epinephrine, which, most people just call adrenaline.
Right.
When the hypothalamus senses a drop in glucose, it triggers the sympathetic nervous system. It's literally an alarm bell. It's designed to make you feel anxious and physically uncomfortable, so you will immediately go seek out food.
So the sweating and palpitations are just side effects of that epinephrine surge.
Exactly. While the neuroglycopenic symptoms, like you said, those are the direct result of the brain actually suffocating for fuel.
Wow.
But what's fascinating here is, there's a critical danger, a saboteur in this system.
Ooh, a saboteur.
Yeah, Washington University endocrinologist Philip Cryer documented this phenomenon. It's known as hypoglycemia-associated autonomic failure, or HAF.
Okay, what does that do?
So if a patient experiences repeated low blood sugar episodes over time, their brain actually habituates to the crisis.
Wait, really?
Yeah, the hypothalamus basically resets its trigger point for releasing epinephrine.
Oh, wow. So the body just physically unplugs its own alarm system.
It creates a state of hypoglycemia unawareness. The threshold for the epinephrine response gets pushed lower and lower until eventually the brain starts starving, hitting those neuroglycopenic levels before the adrenergic alarm ever even goes off.
That is terrifying.
It really is. The patient skips the sweating and shaking completely. They go straight from walking around feeling totally fine to suddenly having a seizure or collapsing.
So if I see someone who isn't sweating or shaking, I naturally assume they're fine.
Yeah.
But the source material says this is actually the most dangerous assumption you can make.
Absolutely. The sickest patients, the ones whose blood sugars constantly dip, they are the exact people who will never feel the crash coming. Just because there's no low battery warning doesn't mean the phone isn't about to die.
That is such a crucial takeaway. Okay, so if a patient's natural alarms are unplugged and the brain has mere minutes of fuel left, outrunning the brain damage becomes a matter of, precise mathematics.
Yes, it does.
Which brings us to the rescue protocol, specifically the rule of 15. Now, when I first read the protocol for fixing a crash, my first instinct was entirely wrong.
What was your instinct?
Well, if my blood sugar is crashing, my brain screams for the biggest, most decadent chocolate bar I can find.
Oh, yeah. Of course it does.
But the clinical sources strictly forbid this. Why is reaching for a Snickers a rookie mistake? Is it like trying to sprint through a mud pit?
That is the perfect analogy, yes. Dietary fat and protein, they significantly slow down gastric emptying.
Okay.
They basically close the pyloric sphincter at the bottom of the stomach, and that delays the transit of everything into the small intestine, which is where glucose is actually absorbed into the bloodstream.
So the sugar gets stuck in the stomach when it desperately needs to be sprinting to the brain.
Exactly. If you try to treat hypoglycemia with a candy bar or, ice cream, the fat traps the sugar. Your blood glucose might not rise for 45 minutes or an hour.
Oh, wow. And by then, the neuroglycopenia is advancing.
Right. Speed requires pure, fast-acting carbohydrates, which is the foundation of the rule of 15 for a conscious patient who can safely swallow.
Right, so you get 15 grams of fast-acting carbs, you wait exactly 15 minutes, recheck the blood glucose, and if it's still below 70, you repeat the cycle.
Yep, that's the rule.
And once they're stabilized, you follow it with a complex carb and protein snack, assuming their next meal is more than an hour away.
The math and the timing there are very deliberate. 15 grams is roughly 4 ounces of regular juice, maybe a tablespoon of honey, or 3 commercial glucose tablets.
It's a pretty small dose.
It is a small, precise dose, and we wait exactly 15 minutes because that is the physiological transit time required for simple sugars to clear the stomach, enter the bloodstream, and actually register on a glucose monitor.
So checking at 5 minutes tells you nothing.
Nothing. And waiting 30 minutes risks further decline.
But the natural human reaction, driven by that primal epinephrine panic we talked about, is to just chug an entire liter of juice.
Which is a massive error because treating a low isn't just about escaping the immediate danger, right? It is about managing the aftermath.
Ah.
If you overcorrect with massive amounts of sugar, your blood glucose is going to skyrocket an hour later. Imagine a type 1 diabetic who wears an insulin pump.
Okay.
They miscalculate a dose, they go for a run, and they drop 100 points in half an hour. The rule of 15 provides a small, titratable correction. It gently nudges them back into a safe zone without causing this massive rebound spike that throws their entire metabolic management off for the next 2 days.
That makes a lot of sense. It's the universal standard for nurses treating alert patients. But if someone is completely unconscious or so severely confused that they can't follow basic instructions, the rule of 15 has to be abandoned immediately, right?
Oh, immediately. Yes. Trying to force liquid into an uncooperative or unconscious patient introduces a massive risk of aspiration. They could literally inhale the juice into their lungs.
So what do you do?
At that point, you bypass the digestive tract entirely. If you're in a community setting, the treatment is glucagon.
Okay.
Historically, this required an intramuscular injection, which, was highly stressful for untrained bystanders to mix and administer during an emergency. But thankfully, we now have Baqsimi.
Right, the nasal spray.
Exactly. It's an FDA-approved intranasal glucagon spray. It requires no needles, and it works even if the patient is unconscious and not actively inhaling.
That is incredible. And what if they are already in an ambulance or a hospital bed?
In that setting, paramedics and hospital staff will use an intravenous dextrose solution. For decades, the standard was pushing an ampule of D50, which is a highly concentrated 50% dextrose solution.
Okay.
But current evidence-based practice is really shifting toward D10, which is a more dilute 10% infusion.
Right, because I would imagine the D50 was essentially the IV equivalent of chugging the entire liter of juice. It just slams the system.
Exactly. D50 acts like a sledgehammer. It damages veins and almost guarantees severe rebound hyperglycemia. D10 corrects the deficit much more smoothly and safely.
It's hard to reconcile this level of precise evidence-based pharmacology with the historical reality of how doctors used to treat blood sugar.
Oh, the history is wild.
Here's where it gets really interesting. Tracing the history of hypoglycemia reveals this recurring theme, the profound danger of blind medicine. Doctors were constantly doing their best to manage a system they couldn't fully see.
Right.
For instance, hypoglycemia barely existed as a widespread medical issue before Frederick Banting and Charles Best isolated insulin in 1921.
That's true, because before external insulin therapy, humans rarely experienced severe artificial drops in blood sugar. The crisis was essentially man-made, an iatrogenic effect of our attempts to treat diabetes.
But instead of viewing these severe crashes entirely as a side effect to be minimized, some practitioners actually weaponized the physiology.
Unfortunately, yes.
In 1927, Manfred Sockel began using massive doses of insulin to intentionally force patients with schizophrenia into hypoglycemic comas.
Yeah, insulin coma therapy.
Right. They starved the brain of glucose day after day, sometimes for weeks, based on this totally unfounded theory that the trauma of the coma would reorganize their psychiatric pathways. We used to intentionally induce the exact medical emergency nurses are now trained to prevent.
If we connect this to the bigger picture, it was a brutal era of medicine. They were purposefully inducing level 3 severe hypoglycemia, risking permanent brain damage and death, long before we understood the cellular limits of astrocytes or neuroglycopenia.
And that blindness extended to diagnostics, too. Look at 1938. Surgeon Alan Oldfather Whipple had a severe problem. He suspected some of his patients had insulinomas.
Right, those rare insulin-secreting tumors in the pancreas.
Exactly, which caused severe hypoglycemic crashes. But he didn't have CT scans or MRIs to prove the tumor existed before cutting the patient open.
And exploratory pancreatic surgery was incredibly dangerous back then, so he needed absolute diagnostic certainty without any imaging.
Which is where Whipple's triad comes in.
Yep. He established the triad we mentioned earlier: documented symptoms, a simultaneous low glucose reading, and complete resolution when given carbohydrates.
If a patient met all three, Whipple knew the physiological mechanics were real and the surgery was justified.
And almost 90 years later, that triad remains the gold standard today because it relies on functional reality rather than just numbers.
It's amazing. But even into the mid-20th century, we were still guessing at the unseen mechanics of the body. In 1959, biochemist Michael Somogyi identified patients waking up with wildly high morning blood sugars.
Okay, yes, the Somogyi effect.
Right, he proposed that they were actually crashing dangerously low in the middle of the night. His theory was that the brain panicked, released a flood of counter-regulatory hormones like cortisol and adrenaline, and caused a massive rebound spike by morning.
Which makes sense on paper.
Right. So doctors spent decades lowering nighttime insulin doses to treat this assumed midnight crash.
And, it was a perfectly logical theory based on the limited data they had. Doctors couldn't stand over a sleeping patient and draw blood every 15 minutes.
Right, obviously not.
But modern technology finally brought us out of the dark. The invention of continuous glucose monitors, or CGMs, allowed us to track interstitial glucose continuously through the night.
And the data proved Somogyi mostly wrong.
It did. The data revealed that nocturnal rebound hyperglycemia is actually quite rare.
Yeah.
Most of those high morning numbers are caused by the dawn phenomenon.
The dawn phenomenon.
Yeah, it's a natural diurnal release of growth hormone and cortisol in the early morning hours that increases insulin resistance. So the treatment wasn't to lower the evening insulin, but to adjust the timing of the basal dose.
Wow.
CGMs allowed us to finally see the true physiological narrative instead of guessing based on the aftermath.
Which brings us to the present day. Even with CGMs and highly refined protocols, the sources emphasize that the science is still evolving, and dangerous misconceptions persist everywhere.
They really do.
Like, the rule of 15 is the standard, but there is an ongoing clinical debate pushing for a rule of 20 for certain populations. The argument is that 15 grams might undertreat larger adults, trapping them in a cycle where they take 15 grams, wait, fail to recover, and have to treat again.
Exactly. It highlights that protocols are baselines, right? Not immutable laws of physics. But the more immediate danger really lies in the myths held by the general public and sometimes even first responders.
So what does this all mean?
Well, the mechanisms behind these myths are crucial to understand. Take the relationship between alcohol and blood sugar.
Oh, this one is huge. Wait, so if you see someone stumbling and slurring their words after drinking, it might not just be intoxication.
Exactly. If you're out with friends, or if you're a paramedic responding to a call, and you see someone stumbling out of a bar, slurring their words, acting combative, the immediate assumption is heavy intoxication.
Sure, that's what everyone thinks.
But that assumption can be lethal if the person is actually experiencing profound neuroglycopenia. The physiology here is fascinating. The liver is a multitasking organ, but it is highly inefficient when it comes to prioritizing those tasks.
Okay, what do you mean?
Well, one of its main jobs is gluconeogenesis. The creation of new glucose from non-carbohydrate sources could keep your brain fueled between meals. However, the liver views alcohol as a potent toxin.
So it drops everything else to deal with the threat.
Precisely. Processing ethanol monopolizes the liver's chemical machinery. Specifically, it depletes an enzyme cofactor called NAD plus LAC.
Okay.
And without that cofactor, the liver physically cannot run the gluconeogenesis pathway. It completely shuts down the body's backup generator.
Wow, so if someone has been drinking heavily on an empty stomach, their blood sugar can crash hours later.
Yes. They appear drunk because their brain is starving. And if a bystander just lets them, sleep it off on a couch, they are allowing the neuroglycopenia to progress unopposed, which can lead to a coma.
That is terrifying. And the liver's prioritization of alcohol over glucose production also explains the major misconceptions surrounding glucagon, right?
Oh, absolutely.
People assume glucagon works instantly, like an EpiPen for allergies. You inject it, and the crisis ends. But glucagon doesn't contain any actual sugar.
Right. Glucagon is merely a signaling hormone. Its only function in an emergency is to command the liver to break down stored glycogen and dump it into the bloodstream.
Which takes time.
It takes 10 to 15 minutes for that metabolic process to occur. But more importantly, if the liver's glycogen stores are already completely depleted, say because the patient has been fasting, recently drank alcohol, or had multiple low blood sugars over the last 24 hours, the glucagon has nothing to work with.
Oh, man.
You can shout on an empty warehouse all you want, but it won't produce any inventory.
That mechanical limitation totally reframes the entire clinical picture. And it also broadens the scope of who is at risk. While insulin medications make hypoglycemia far more common in diabetic patients, they are not the only population vulnerable to these crashes.
Not at all. I mean, we see severe reactive hypoglycemia in patients who have undergone bariatric weight loss surgery.
Dumping syndrome.
Yes, dumping syndrome.
Yeah.
Because the anatomy of the stomach has been altered, a high carbohydrate meal empties into the small intestine far too rapidly. And this triggers an inappropriately massive release of endogenous insulin, which then sweeps all the glucose out of the blood, causing a severe crash shortly after eating.
That's wild. And the sources also heavily emphasize the danger of accidental ingestion of sulfonylurias, particularly for pediatric patients.
Yes, sulfonylurias are oral medications that force the pancreas to secrete insulin. And unlike a rapid-acting insulin injection that, peaks and clears the system relatively quickly, these pills are designed for prolonged action. So if a toddler accidentally swallows a grandparent's sulfonylurea tablet, the resulting hypoglycemia can be relentless, lasting for many hours and requiring extended hospital monitoring and continuous dextrose infusions.
It really becomes clear that managing hypoglycemia isn't just about knowing the textbook definition. It's about respecting the sheer mechanical wonder and danger of the body's fuel system.
It absolutely is.
We've traced the brain's unique vulnerability from the ADA's functional definitions through the life-saving precision of the Rule of 15 and past the dark history of insulin comas, all the way to the modern myths that still trick us today.
And for nursing professionals, rapid recognition is just a foundational skill because a miss low can escalate from mild confusion to a seizure in a matter of minutes.
All right.
But the broader impact of this condition extends far beyond emergency medicine. Hypoglycemia is a leading cause of preventable hospital admissions. And the physiological terror of that adrenergic alarm system, it leaves a lasting psychological scar on patients.
I'm glad you brought that up. Looking at the literature, it seems like the sheer terror of this experience causes a behavioral backlash. The sources describe a phenomenon called defensive hyperglycemia.
Yes, this is so important.
Patients who have suffered severe crashes are so traumatized by the feeling of their brains suffocating that they intentionally keep their blood sugars dangerously high. They run their glucose levels at 200 or 250 every day, preferring the abstract, long-term risk of organ damage over the immediate visceral panic of a crash.
The fear is profound. And this raises an important question. It forces us to reevaluate how we view patient behavior in a clinical setting.
It absolutely changes the perspective. The medical community frequently labels patients who run chronic high blood sugars as non-compliant, which carries an inherent judgment.
It implies a lack of discipline or care.
Exactly. But perhaps what we call medical noncompliance is, in reality, a deeply rational, protective human response to the terror of hypoglycemia.
When you understand that the brain will do anything to avoid starvation, a patient's decision to avoid the edge of the cliff makes complete physiological and psychological sense.
It is not just a frustrating number on a chart. It is a constant, exhausting tightrope walk. So the next time you feel that sudden mid-afternoon crash, the shakes, and the urgent need for a snack, take a second to appreciate the incredible high-stakes alarm system firing off to keep your brain online. Until next time, keep digging deeper.